All right. I think we're live, so we're going to go ahead and get started. Um, Thank you all for joining us today for World AIDS Day. This is a day dedicated to honoring those we've lost and supporting the people living with HIV. So, my name is Fryda, and I'm an advocate with AIDS United, and I'm joined by my colleague in the field, Daniel Raymond from the National Viral Hepatitis Roundtable. So, thank you so much for joining us today.
Sure, Frida. Thank you for having me.
Much appreciated. So, today we'll be discussing the importance of advocating for hepatitis and also just really just involving what World AIDS Day means to us and why we make such a point to have these conversations, but also making sure that we're intertwining the work that is also being done on the viral hepatitis end of things. So, when discussing viral hepatitis, what are we normally talking about, Daniel?
Yeah, I think people might be familiar with the idea of hepatitis, inflammation of the liver, that could be caused by multiple sources. But when we talk about viral hepatitis, we're talking about different viruses that can lead to short-term or chronic infection. And I think that this is part of the reality of living with HIV for a lot of people, just given overlapping transmission routes, whether that's perinatal transmission, sexual transmission, transmission through injection drug use. So, a couple of the most significant ones for people with HIV are hepatitis B and hepatitis C. Uh, they are not physically related as viruses, but they both take hold in the liver and can cause liver problems, which can be significant for people living with HIV. Hepatitis B and hepatitis C can be lifelong infections. Hepatitis B is preventable through vaccination and treatable. Hepatitis C is curable, but we have seen about 25% of people in the United States living with HIV are co infected with hepatitis C. And in countries around the world where their local AIDS epidemics have a substantial proportion of people acquiring HIV through injection drug use, that is also a major form of transmission for hepatitis C. So that's where we especially see a high burden of co infection.
And I think it's so important to review even the basics because, as we know as advocates, we sometimes lose those bits and pieces, right? And sometimes we aren't able to educate everyone about all of the information. So, when doing HIV advocacy, why is it important to include viral hepatitis in our conversations?
Yeah, I think there's a couple of reasons. One is that while we've seen tremendous progress uh, in people's access to antiretrovirals, access to effective HIV treatment, that we also recognize that when somebody with HIV goes in for medical care, they have to deal with a lot of different things. They have to deal with stigma. We know that HIV is tied up with a lot of social determinants of health, issues like medical mistrust from experiences of discrimination or stigma, all of that stuff, and that an effective patient provider relationship is necessary not just to maintain access and retention in care, but to give people a chance to open up about the range of health challenges they face because their HIV provider might be the most trusted health professional in their lives. So, whether that's sexual health issues that might relate to risk for acquiring hepatitis B if you're unvaccinated, acquiring hepatitis C, and this goes for people who might be on PrEP too, that being able to have those full conversations allows both the patient and the provider to talk about health holistically, the whole person's health, that we are very concerned about their HIV care, but that's often just the front door to addressing the range of health concerns and issues that people have been carrying in with them and perhaps never having a chance to address.
Right. And you're hitting on a lot of amazing information. Thank you for that. One of the things that we are also very aware of is how impactful policies are in our healthcare system and how they are applied to our everyday lives. So, what are some federal policies that are currently in place and in progress or in progress that people should be aware of and that we should be discussing?
Yeah, I think, especially for an audience that's really tuned into HIV, that sometimes it can be a shock to hear that we have way less funding for viral hepatitis at the public health level, that we have a program at CDC, the Division of Viral Hepatitis, that does not have the level of funding that it needs. So a lot of the focus for advocates has been saying, we've seen what's possible when the resources become available. We've seen how the funding that we've collectively advocated for on the HIV side at CDC has benefited and strengthened health departments and community responses. We would love to see a parallel or sizable investment in viral hepatitis at the same time. We've also seen the power that a program like Ryan White can play in terms of supporting providers and clinics, financing treatment through ADAP, making sure that there's the assistance and the infrastructure needed, and that if that's what you're used to, you might be shocked to hear that we don't have anything similar for viral hepatitis, for hepatitis B, for hepatitis C. We don't have the same network of clinics, the same opportunities for a safety net program like ADAP to finance drug purchasing. Now, ADAP programs generally cover hepatitis B and hepatitis C medications for people who are co-infected, but for people who do not have HIV and are simply pursuing care for hepatitis B or hepatitis C, think of the case of hepatitis C in particular that uh, nearly 10 years ago, many people will know that we had a new generation of antiviral drugs, direct acting antivirals to treat hepatitis C that were transformational. This was kind of hepatitis C's moment, somewhat parallel to the late 90s when we finally had the cocktail, hard, highly effective antiretrovirals. And in the case of hepatitis C, these drugs cure hepatitis C within a 2 to 3 month course of treatment.
Mhm.
Now, what happened though is you would like to think that everybody rallied around and said, "Oh, we've got to make these drugs available for everybody. We've got to get everybody treated. We've got to get
Right.
everybody cured." And there was a lot of enthusiasm from patients, providers, public health leaders. However, the initial cost of these medications led to sticker shock among payers, private insurers,
Mhm.
Medicaid, Medicare, because there was so much pent up demand because all these people who'd been waiting for this cure were standing in line, and the total spend to the healthcare system in those early years was significant.
Right.
Unfortunately, as a response, a lot of payers, commercial and private payers, but also state Medicaid programs said, we just can't afford to treat everybody and get them all cured for hepatitis C. So we're going to start by triaging. We're going to say that you need to be treated by a specialist. You need to have signs of some degree of liver damage.
Mhm.
You need to be sober and abstinent from drugs. And we started to see these restrictions imposed. We've been tracking them in state Medicaid programs, along with our partners at Harvard Law School Center for Health Law and Policy Innovation, for a number of years in a project we call Hepatitis C State of Medicaid Access. And for a number of years, it was very hard for a lot of people to get Medicaid to reimburse and cover the cost of curing their hepatitis C. And while we've seen some fantastic progress in these state Medicaid programs, several of them removing restrictions, loosening restrictions, or even removing prior authorization requirements altogether for at least people presenting for the first time for treatment, that we still have a long ways to go. And so that struggle, that idea that we've got the promise of a cure, but you may not be able to access it, or if you are on Medicare that or private insurance, you might have high out-of-pocket costs, or you might need to demonstrate that you fit the criteria, has been incredibly frustrating. One glimmer of hope, though, on the federal policy side is that under this administration, the White House has proposed a national hepatitis C elimination strategy, which does factor into the fact that we need to not only get these cures to people through making sure that the financing works and incentivizing the healthcare system to cure as many people as possible, but we also need to find the people, diagnose them, link them to care, support providers and clinics with the infrastructure that they need, training, capacity building. And so they're proposing a 5-year program aimed to do exactly that, to push us on the course to viral hepatitis elimination. It would require legislation from Congress. The cost of this program would be several $billions, but the math works out that we know that treating people, curing people reduces healthcare expenditures, not just from liver disease, but a lot of ancillary diseases, and ultimately saves lives. So we're hoping that in December we will see legislation introduced from Congress that we can collectively rally around and push for, because I think the key message here is that getting our country on the course to hepatitis C elimination is got to be an important priority for all of us, including HIV advocates, because it reduces a lot of the not just the medical problems of co-infected people, but also the burden on Ryan White programs to address all of these co-infections as well.
Right. And thank you so much for touching on all the barriers that we see as advocates, and that most of the things and the people receiving services are rooted in stigma. So we are seeing that in mostly, again, also for touching on co-infection. So how does that how does the presence of other health conditions such as like HIV and TB impact the management and the treatment of viral hepatitis? If we're going to really look into more of the treatment and the screening and the diagnosis.
Yeah, I think the good news is that there's been a lot of work done by different guidelines committees, ASLD, the American Association for the Study of Liver Disease, and IDSA, the Infectious Disease Society of America, have worked on hepatitis C guidelines, treatment guidelines that include considerations about co-infection, including co-infection with HIV. Similarly, ASLD has hepatitis B treatment guidelines, and the HIV guidelines also include these co-infection issues. There's a lot of synergy between treatment and also prevention between HIV and hepatitis B, because some of the drugs that work against HIV also work against hepatitis B. There's also a lot of benefits to being hepatitis C among people co-infected with HIV. And for the most part, the drug interactions that we might be concerned with whenever we're trying to kind of figure out, do we treat HIV first? Do we treat hepatitis C first? Can we treat them both together? It's safe to treat them both together, very manageable. And the drug interactions are known and established and are completely within the course of normal patient care. TB has been a consideration, not just for HIV, but for hepatitis B as well, because a high proportion of people in the United States with hepatitis B are foreign-born and come from from countries that also have endemic tuberculosis, and so a lot of people might have latent tuberculosis infection. And so there's always some questions there about when to treat, about which treatments are safe with each other. But I think the thing that I find optimistic is that once you get people in the door for one of these infections, you open the door to treating both or all of them.
Yeah, and that's perfectly said. One of the things that we are also working around is harm reduction, right? So, how does that play into our discussions, and how does that look for not only our work as advocates, but also on a regular day to day for folks that are coming in and receiving any and all services when it comes to these things?
Yeah, one thing I think about in the context of harm reduction and the relationship between HIV and viral hepatitis, a lot of people remember several years ago, around 2015, the huge HIV outbreak in Scott County, Indiana, among people who were injecting prescription opioids. Now, it was, perhaps the biggest recorded HIV outbreak ever seen in the United States. This cluster of cases in a relatively small county that went into the triple digits. And virtually all of them had hepatitis C and had probably previously been infected with hepatitis C, but the hepatitis C was only detected after they tested positive for HIV because there wasn't a testing program in place. And so often for people who inject drugs, hepatitis C may be the first time that they experience an infectious disease consequence of their injection drug use. And it's kind of the canary in the coal mine that a lot of people who inject drugs end up acquiring hepatitis C fairly early after they start injecting. So when we talk about harm reduction, we talk about certain services programs to reduce the transmission of of these viruses that will benefit both hepatitis C, HIV, but also hepatitis B for people who are old enough, say in their 30s or 40s, that they were too old for school-based hepatitis B vaccination, and so they remain unvaccinated. So I think that there's a common core constituency here, whether you're concerned about overdose, HIV, viral hepatitis, that syringe services programs have to be an essential part of our public health infrastructure. They are on the front lines of prevention, but also in terms of engaging people who are often disconnected or have fraught relationships with the broader healthcare system. The same would go for overdose prevention centers as well. And uh, medications for opioid use disorder, methadone, buprenorphine play critical roles across all of these infections.
Yeah, thank you. And it is so important to continue to uplift all of the harm reduction practices that we have. We definitely have programming around syringe services, but also any safer use and safer consumptions. And a lot of these things are rooted in stigma because we definitely should be also talking about safer smoking kits, right? And these are just things that should be normal and natural for folks to have conversations on and to access overall, because it does reduce any and all of the things that we're continuing to talk about. I do want to circle back around, and you did bring up some of the policies and guidelines of these things, but how does it work? Does it vary across regions when we're working on a federal stage? Yeah, can you tell us more about that?
Yeah, I think there's probably a few different layers to this. So I mentioned earlier that state Medicaid policies for covering hepatitis C drugs are set by the state. So that even though Medicaid is a federal program, it's technically a federal and state partnership, and states have a lot of latitude in how they design and construct their Medicaid program in terms of what they cover, in terms of whether they contract with managed care organizations, in terms of their formularies. So this is something that we tend to address on a state by state basis. Another piece that's important at the state level is that we have seen states like California allocate funding in their state budget towards viral hepatitis. We also see a lot of variation for one important setting for hepatitis B, but particularly hepatitis C care as well as HIV care, is state prisons. And state prisons have a wide variety of practices, policies, and standards for whether and who they test, how often they test, whether the testing is opt in or opt out, and what level of care and treatment they provide for people with hepatitis C. So that is clearly a state advocacy issue as well. But all of these also feed up to the federal level. That when we're talking about even getting the data and the numbers from surveillance, that there's a strong need to strengthen our surveillance systems for viral hepatitis. A recent report came out from HepView in partnership with NASTAD demonstrating that our surveillance system at the state level for viral hepatitis is nowhere near where it needs to be, and that states struggle to complete core functions because of lack of staffing and lack of funding. That ultimately goes back to greater federal investments in CDC's viral hepatitis program that can then go out to states. Similarly, that we want to continue to expand resources for harm reduction programs. And while states and localities have stepped up in many places, a lot of places are really going to be looking to SAMHSA, looking to CDC to support and finance the growth and expansion and sustainability of their harm reduction programs. And that's going to take all of us working together to make the case to Congress and the administration about why we need those funds.
That's right. And in what ways can the healthcare system empower individuals living with viral hepatitis to actively manage their health and advocate for their needs? You very much hit on a lot of amazing points on how we have administrations be a very large part of this. How can we continue to activate that in other spaces as well?
Yeah, well, I think about this in a couple of different ways. We have at National Viral Hepatitis Roundtable, we have networks of patient advocates and we have networks of provider advocates, and we talk regularly to people in the field, people across the country about what they're seeing, what they're experiencing, and what innovations uh, they're using or what challenges they are trying to address. So I think that one of the key themes for both hepatitis C and hepatitis B is the challenge of diagnosis. That some of that is really just familiar to people with HIV. Oh, the moment of do I get tested? Do I really want to know whether I have this potentially life-changing, life-threatening infection? But some of it is also the diagnostic tools that we have. We have uh, much narrower set of diagnostic tools in our toolbox for hepatitis B and hepatitis C. We have seen innovation in tests used in other countries that we would love to bring here to the United States, not just for healthcare systems, but also for testing opportunities outside of the traditional healthcare system, whether that is testing events in community centers and churches, or also testing in the field and public health efforts like syringe services programs, outreach to homeless encampments, testing in drug treatment programs. So I think that there's a lot of work that can be done to streamline the process of hepatitis care, whether we're talking about hepatitis B or hepatitis C for patients. But when you talk about empowerment, I think also the concept that hepatitis C is curable. We've heard from a number of patients, a number of providers, that that can be a game changer in terms of people's sense of their own power and capacity to manage important health condition. That journey of addressing your hepatitis C, whether it's for somebody in recovery with somebody who's newly diagnosed, can really start to feel like you're taking some control back over your body and your health that has a ripple effect on not just your willingness to engage in healthcare and address other healthcare conditions, but that sense of stigma uh, that gets so internalized so often. I think that's also an important factor for hepatitis B as well. I mentioned before that there's a lot of the hepatitis B cases in this country are among people who are foreign born. And that can be very fraught for so many different ways. Stigma, the racial politics around immigration, a lot of cultural issues, a lot of challenges in access to healthcare depending on your legal status as well. But we've seen through some of our partners, through Hepatitis B Foundation's Hep B United Network, really tremendous and empowering grassroots community-led innovations to start people talking about hepatitis B, diffuse the stigma, make people feel comfortable accessing healthcare, disclosing to their family members. And so a lot of it really mirrors some of the lessons that we've learned from HIV about how powerful those forms of support are from your family, from your healthcare provider, from your community, and that getting the conversation started can be a very hard thing. But if we really want to support people in accessing healthcare, that has to be part of the equation.
Thank you. And there are so many ways that people can get involved. What are you all currently working on, and how can people get in touch with the work that with you all and the work that you all are doing?
Yeah, I would love to encourage anybody to visit our website, which is mvhr.org. There you will find ways to sign up for our monthly grassroots advocacy network calls. You can sign up for Voices for HEP, for our patient advocacy network, our provider advocacy network. This is a really great time to get plugged in because we feel like we're on the threshold of a major advocacy push that's going to take everyone for this national hepatitis C elimination plan. We are hoping to see legislation introduced very soon. I'm hoping it will be our holiday present before the end of the year. And that's going to need everybody's voices. But we also very much, I mentioned our work in terms of treatment access and payer restrictions. Would love to hear about what you're seeing from your state. Would love to be able to call on you so that when we do see these Medicaid restrictions, when we do hear about issues that we've heard about recently in terms of some private insurer issues with hepatitis B treatments, that we can rally together, strategize together, and ultimately advocate together, because it's going to take all of our voices.
It really does. And thank you so much, Daniel, for all the work that you do and your expertise. It's just so valuable. We really appreciate your time with us. So thank you. Thank you for all this.
My pleasure, Fryda. Thanks to you and all your colleagues at AIDS United and everybody commemorating World AIDS Day today.
Very much appreciated. And thank you all for joining. Please feel free to reach out in case you have any questions. And yeah, I appreciate you all for your time too. Thank you.